as a do not code. Improved pharmacologic agents. And that's what's led to this term of 40 or 50 years. Family support for the child. Coping with emotional needs of the child and family. Child requires treatments multiple times each day. Frequent hospitalizations. Implications of genetic transmissions of the disease. Usually the parents, after they see how this child is, they go for genetic counseling to find out what their chances are of having normal children. Defined as inability of respiratory system to maintain adequate oxygenation. This respiratory failure, this is the reason I put the CPR for the infant and child in there. Any child with any chronic respiratory problem could be a respiratory failure. Terms to know. Work of breathing. Apnea, which is the absence of breathing. Respiratory insufficiency. And respiratory arrest, which is a cessation of your respiratory system to work. Clinical manifestations of respiratory failure, diagnostic evaluation, therapeutic management, ventilation techniques and strategies, and our nursing considerations. We need to watch their intake and output. We need to watch their O2 levels. CPR, pediatric cardiac arrest, frequently represents the terminal event following respiratory failure or progressive shock. Pediatric cardiac arrest rarely results from sudden cardiac collapse, as in adult populations. It's usually respiratory arrest. Children stop breathing, their heart stops from respiratory situations, not from a heart attack like adults do. It varies with age and the underlying chronic medical conditions. Out of the hospital, causes include trauma, SIDS, poisoning, choking, asthma attacks, or drowning. In hospital, causes typically due to underlying conditions. CPR, Pediatric Advanced Life Support, which is PALS. These are the standards of care for what to do with respiratory arrest. And here's the child and infant video again. Really a good video. And that's the recovery position. Recovery position for child after respiratory emergency. It's the easiest way they can breathe. It takes all the pressure off of them. When you lay on your back, it's harder to breathe than when you lay on your stomach or on your side like he is side lying. And it allows the lungs to expand their fullest. This is the child with the gastrointestinal dysfunctions. We talked about respiratory, now we're going to talk about the gastrointestinal. Failure to thrive, spitting up or regurgitation, nausea, vomiting, diarrhea, constipation, abdominal pain, distension, GI bleeding, jaundice, dysphagia. What's dysphagia? Hypoactive, hyperactive, or absent bowel sounds, fever, and these all lead to types of dehydration. There's isotonic, which is the loss of same amounts of electrolytes and H2O. Hypotonic, where electrolyte exceeds the H2O loss. So there's more electrolytes going out than water. Hypertonic, which means that there's more water than electrolytes being lost. Diagnostic evaluation, pre-illness weight loss, and you compare to 10%. If an infant baby loses 10% of their weight through regurgitation and diarrhea, this is a child that's dehydrated. Their skin turgor, you look at that, you see in infants sunken eyes, lethargy, and response to stimuli. They just lay there. Therapeutic management. See the diarrhea page on 821. Good list there. Nursing care management. You want to watch their I&O, their vital signs, their skin, their fontanelles, their mucous membranes, their weight, and their sensory alterations. Calculate the child's weight in kilograms. Allow 100 milliliters per kilogram for the first 10 kilograms of body weight. 50 milliliters per kilogram for the 10 grams after that, of next 10 grams of body weight, and then 20 milliliters per kilogram for the remaining body weight. One daily fluid. A child weighs 32 kilograms. We're going to put 100 times the first 10 kilograms, 50 times the next 10 kilograms, and 20 times 12 for the remaining body weight equals 240 milligrams. 1,000 plus 500 plus 240 equals 1,740 milliliters in 24 hours. It's a lot of fluid. Child weighs 8.5 kilograms. You're only going to give them 850 because you are less than 10 kilograms. So the first 10 count. 14 kilograms, you want to go 100 times the first 10 and 50 for the next 4. So that makes 1,224 hours. Diarrhea. Acute diarrhea is the leading cause of illness in children under 5. 20% of all deaths in developing countries are related to diarrhea and dehydration. Acute infections, diarrhea, variety of causative organisms. Gastroenteritis, enteritis, colitis, or enterocolitis. There's acute infectious gastrointestinal tract. There's chronic, intractable diarrhea of infancy. What's intractable mean? Chronic, nonspecific diarrhea. Don't know why. Rotavirus. You can have Salmonella, Shigella, Campylobacteria organisms, Giardia, and Cryptosporidium, Clostridium difficile, and antibiotic therapy. And there's a page, 18 to 1821, that great table there in your book. Diagnostic evaluations. You want to look at your history, your lab values, your urine and stool cultures as needed. Therapeutic management. Assess the fluids, rehydration, fluid therapy, and reintroduce of adequate diet, oral fluids, or IV. These are fluids that are like Pedialyte. Nursing considerations, educate the caregivers, count the wet diapers. Make sure that the fluids are not caffeinated, nor fluids high in sodium. Concept of oral rehydration. Rehydration solution of 75 to 90 milliequivalents of sodium per liter. Give 40 to 50 milliliters per kilogram over the first 4 hours. Then you maintain hydration with solution of 40 to 60 milliequivalents of sodium per liter, and a daily volume of maintenance dehydration is less than 150 milliliters per kilogram per day. Prevention of diarrhea. You teach personal hygiene. Most diarrhea is spread by the fecal-oral route. How many people do you see in these bathrooms today that go to the bathroom in public places and come out and don't? They look at their face in the mirror and they take off. They don't wash their hands. And if these are food handlers, well, clean water supply, protected from contamination, careful food preparation, and hand washing. Hand washing ought to be at the top of that list. Constipation, an alteration in frequency, consistency, or ease of passage of stool. May be secondary to other conditions. Idiopathic. No known cause. Chronic constipation may be due to environmental or psychosocial factors. Constipation in the newborn period. First meconium should be passed within 24 to 36 hours of life. If not, assess for Hirschsprung's disease, hypothyroidism, meconium plug, meconium ileus, which comes with cystic fibrosis. So we're always looking for that brand new baby to give us that meconium stool. Constipation of infancy, often related to diet. Constipation is exclusively breastfed infant, almost unknown, and that is the truth because breastfed babies have those nice soft little stools. Infrequent stooling may occur because of minimal residue from digested breast milk. Formula-fed babies may develop constipation. Interventions. What interventions can we do for these guys? Often result of environmental changes in control over body functions. Some little people hold on. And how many times have you ever couldn't deal with that first urge? You were busy or there was no bathroom around and you said, okay, I'll just wait a while. And then, guess what? Now you can't go. You missed your opportunity. So your body functions work like that, and these little people can do this. They can hold on to it, and that's their way of controlling. Encoparesis, what is that? Inappropriate passage of feces, often with soiling. May result from stress. Nursing consideration for constipation. You want a history of the bowel patterns. Look at their medications. Look at their diet. You want to educate the parents and the child. Dietary modifications upon age appropriate. There's all kinds of fiber wafers, fiber bars, fiber everything today. So it's very, very, if it's not a pathological reason or a disease-oriented reason, it's very easy to get fiber into your diet. They make cookies, they make all kinds of good tasting things. Hirschsprung's disease, it's also called congenital ganglionic megacolon. Mechanical obstruction from inadequate motility of the intestine. The incidence is 1 in 5,000 live births, more common in males and in Down syndrome. Absence of ganglion cells in the colon. And there's Hirschsprung's. It shows you the rectum and the aganglionic portion and the distended sigmoid colon because it just doesn't go down. Usually includes the rectum and the proximal colon. The accumulation of stool will cause distension. Failure of internal and sphincter to relax. Enterocolitis may occur. What's enterocolitis? What's colitis? You find it on X-ray with a barium enema, anorectal manometric examination, and confirmed diagnosis with rectal biopsy.